for joining our webinar. And today we are having and hosting for the second time Prof. Greber from Brazil, who is going to teach us today the use of bends and loop for refinements of occlusion. My name is Mo. I'm a specialist orthodontist from Scotland, and I will co-moderate this webinar along with the amazing Mark Wertheimer, who is a consultant orthodontist and past president of South African Orthodontic Society. However, I will give the stage to Mark to introduce Kleber to the audience. Mark, the stage is yours.
Mo, good afternoon. Good afternoon, Kleber. Good to see you again over here.
Excellent.
Kleber is,
Mark, it looks like you have very big ears.
I just have to sit in the right place like that.
Yeah, it's not. There's no significant difference actually. That's no significant.
Okay, so Prof. Morales is an orthodontist from Brazil, and he graduated with his orthodontics degree from Araras in Brazil. His time is devoted to the practice and teaching of orthodontics, and he's trained more than 700 students in his 21 years in orthodontics. He's lectured both nationally and internationally, and he's currently dedicated to writing books and scientific articles, as well as generating content for the web for online courses. He is the creator and director of Orthodontic Solutions Project, which offers orthodontists from all over Brazil tips, courses, and ebooks in order to promote the practice of professional and safe orthodontics. He's also published an ebook which addresses in practical and didactic way the concepts related to extractions in orthodontics. I think probably the most important thing about him, though, as far as I can make out, is that he has the same favorite song as me.
It's true. This song, but can you tell me, Greber, what's the meaning of the word that Madonna used to sing, Lex Bonita? What's that? What does it mean?
Beautiful island, the beautiful island. La Isla Bonita means the beautiful island.
Ah, La Isla Bonita.
That's it.
Very good. So, hola, Greber. I'm very glad to have you here. I will go through some housekeeping, ladies and gentlemen. So, recording is not allowed at any time. This is a breach of the confidentiality and the copyright of the speaker. We are not going to issue any certificate from attending this webinar. Also, the chat and the question and answer section box or functionality will be disabled. However, we will be happy to collect your questions at two-phase during the webinar to make the webinar constructive and useful for everyone. So I want everyone to go to his mobile phone or her mobile phone and just type the following: www.pollev.com/almuseum. And I just want to test whether, POLLE, again, www.pollev.com/my surname. And I'm going to use it to collect question after 1 hour, and then we'll have another question and answer session after at the end of the presentation. Of course, there will be informal question that I will raise to Greber during the presentation, just to clarify for a few things. So can you tell me first, where are you based now, guys? Just to see the distribution of the people. So you can see that there's people from Sydney. That's amazing because our webinar is 4 o'clock. We expect some people from Sydney or I'm not sure where exactly, but probably New South Wales. People from Philippines, Thailand, India, Pakistan, Middle East, Africa, Central Africa, North Africa, even Russia, Scandinavian country, North America, East Coast, and of course your motherland, South Africa. South America. We have a good distribution of people, from around the world. So 1 continent, 2, 3, 4, 5, 6. The only continent that we don't have an audience is the Antarctica and Arctica. So it's fine.
Good.
since Mark is his next job will be safari tour guy, because this is what we will talk about. I told him, listen, if orthodontics just collapse, I will, because I'm from the Middle East. I'm very good in falafel, so I can make a restaurant of falafel. And next to me, Mark will open his shop for safari tour, and we sell falafel to the tourists. And it will be fun, So anyway, Mark, maybe because he's safari tour, he might invite some of his polar bears, and they can join our webinars. So, okay. So, ladies and gentlemen, this is the platform that you are going to use when you raise your question. And I'm not going to take more time from you, Gleber, but the stage is yours now.
Okay, my friend, thank you very much. Thank you for the invitation. I'm here again with you. For me, it's an honor, an enormous honor to be again with you here to address another topic that you asked me to. And this is something that I love to talk about, because this is something that I teach a lot here in Brazil and in other countries, which is the bands and loops to the orthodontic refinement. So this is something that I really love to talk about. Thank you again. Thank you, Mark, for introducing me. Thank you, Mo, for inviting and being this host, this fantastic host that you've been lately with your project. And I'd like to thank everybody who's in touch with us now to see this seminar.
There is one person that you didn't thank, actually your family and yourself, because you are the one who should be thanked, not us. You are the one who's giving your time. So thank you so much. And thanks to your wife. What's her name?
I'm sorry, what to say?
What's the name of your partner?
Manuela.
Manuela. So send my regard.
Wife, yes.
Yeah, send my regard to her, Manuela. So, yeah, now we can see your screen. And ladies and gentlemen, I would like you to welcome Gleber to this webinar. And I want to see a lot of raised hands as a symbol of a big round of applause to this amazing guy. So I'm sure that you can see a lot of hands has been raised on your screen. Can you see it?
Yes, I can see it. Thank you very much. I'm raising my hand to you too, Frank.
Take care. Start now.
Very good. Okay, so let's go. As you know, my name is Kleber. I'm from Brazil. I'm from this beautiful city that I live in, Salvador. It's located in northeastern Brazil, the state of Bahia. It's a colorful place full of joy. It's very good to live here. Indeed, I showed this picture before. This is the place where I live. This is the place where I'm now speaking with you now. Salvador, this city here, it's home for 3.5 million, almost this. And this is a panoramic view of my city. I work somewhere here in this position, and this is the place where I go almost every weekend to spend time with my family. This beach here, which now is empty, as you can see, because of this pandemic, outrageous pandemic that we are going through now, every one of us. So this is the place where I'm going to return in a few. I expect a few days to get a good time have a good time with my family. So, guys, what I'm going to start now is a presentation about bands and loops for refinement in orthodontics. Actually, it's more than that. I'm going to show you the way I do my things in my work, my practice, my day-to-day practice. And this is the slide that I like to begin with. I like to start my presentation with, because it's related to what I'm going to say now. Look, you'll see during the presentation that I'm doing things my way, and you may say, well, I wouldn't do this way that he's doing this correction. I would do another way. I would do Invisalign. I would rebond the brackets. I wouldn't do this bond because I don't like it. Guys, it's just another tool for you to have in your armamentarium, you know? So if you have just one tool, as I see some people here in Brazil say, I don't work, I just work with Invisalign, with aligners. All my cases I treat with aligners, and we know that it's possible to treat almost all cases with aligners. It's true, but is it wise to do it in order to do every treatment, you just use one tool? Don't you want to have more than one tool in your armamentarium to work with? to work softly with some kind of corrections that we can do with other tools like bands and loops and stuff like that. So this is the way I'm going to address my presentation today. I'm going to show the way I do things based on the solid science. Of course, it is outside of science. There's nothing that we can show, but it is mixed with my own experience, my own way to do things. So if you, during this presentation, think I wouldn't do this, you might be correct. This is the way you do, and this is the way I'm doing, and I'm showing you another way to do things, or the same way you're doing, just in order for you to know that it's possible to do that way. So let's start saying something about bands and loops in orthodontics. Let me control my time here. And Mo, anytime you want to interrupt me to ask questions, you are allowed. Please do that in order to make the presentation more dynamic. So you can do that anytime you want, okay?
Thank you.
You're welcome. Bands are made in order...
As you can see, I'm trying now just to adjust my my camera because I don't want the middle third of me to be visible, and I want to show you guys. Okay, I need to put my jackets and slipper. I don't want to show the slipper as a way to respect for the audience and the speakers. So I'm just trying to adjust it so only that part will be visible. Go ahead.
Good. I'm not showing my what I'm wearing now because I'm wearing something that's not very good to show. So let's move on. So bands are made in order to correct the position of tooth, of course, or group of teeth, as you will see. They are named according to the movement they impose on teeth in first, second, or third order bands. I intend to show you each one of those. So night-tie wires, as we know, they may not be completely efficient to tackle some nuance of poor dental positions, meaning sometimes you have stubborn teeth that don't go to the position that we want them to go using just night-tie wires. Maybe they may not have the right stiffness, they may not have the right range of activation. So sometimes we have to replace those night-tie, those beautiful night-tie wires with our bands and loops, and that's what I'm going to show you now. And so here we have examples of first order, second order, or third order bands. So this being the first order band, the bands that are made horizontally. The second order bands or loops are made vertical position, okay? And the third order bands, as we know, are the toys. So the first thing that we have to keep in mind is that we don't want to do bands. We would like to have just a smooth way to go from the beginning to the end of our treatment without the need of doing this kind of bands, because it takes time in our office. It's time consuming. If you have something to do in your office, to do things to go smoother, to go directly without the need of stopping and going backwards to do things again. But sometimes you have to do this, okay? In order to avoid these bands, the first thing we have to keep in mind is that finishing starts in the beginning of the treatment with the correct positioning, and even before that with our treatment planning, taking the face in first position to do this treatment planning, the smile, the position, the upper lip, and the upper incisors position, things like that. And so if we want to avoid bands, the first thing we have to do is to plan. So the height and angulation should be carefully checked. We can make changes between heights when we will put our braces on. So we have to avoid during the bonding, the excess of the composite. So these are things that we all know that are important. And if we want to plan a good bonding position for our brackets, we have to keep in mind that this is something that we should pay attention all the time. The position of the lip and the upper teeth in a rest position, because this is something that we know people think it's attractive. We know lay people know that it's attractive. Showing a certain amount of upper teeth during a rest position and a smile position and our lips smiling, it is important. So we know that for lay people and for orthodontists, about 2 millimeters of showing these incisors is good for male, and 3.5 millimeters, or a little bit more than that, good for female. So this is something that we know. And knowing that, we have to keep in our minds that things change with time. We show less upper incisors and more lower incisors during time. This is something that happens to human beings, of course. And this is something that we have to keep in mind to do our treatment planning. If you are planning to do some intrusion on the upper arch, you have to keep in mind that things will change with time. If you're doing this in a 20-year-old girl, for example, you have to understand that when she's 40 or 50, she will show less and less incisors. So you have to plan for aging phases too. And so this is something that we understand that it resembles youth when you have exposure of this incisor during rest. You can look at this woman here, and you know that you probably think that she's about 50 years old. I think something like that, 40 something or 50 years old. Actually, she's 35 or 36 years old at this time here. What plan to change this? And that is important since the beginning of our treatment planning. I'd like to expose a little bit more. I'd like her to show a little bit more incisor during rest. And this is something that I have to plan for and to extrude those incisors if it is possible with orthodontic compensation, if not with orthodontic compensation or surgery. But this is something that I have to plan to give a best exposure of teeth to those women, especially women. And here a little bit more of exposure, and here a little bit more. And I don't know how you think in your Mo, are you there?
Yeah,
can you answer me? Yeah, can you answer me something here, just in order to the discussion of these cases? Which one of those exposures do you prefer when it's for you? You're going to treat your patient, not asking the patient for that. But if you were to decide this, what kind of exposure would you decide? 1, 2, 3, 4, or 5?
I'm between 1 and 4.
Between 1 and 4. Same thing with me. I think that 3 is too much and 5 is too little. So this is something that I do expose to my patients more, because I want them to, with me, share their treatment planning, our goals, So I ask them, do you want to expose more or less teeth? Because the treatment belongs to the patient, not to us, as you know. So I usually do this.
If the patient is female, I will go more to art 4. If the patient is male, I will go more to art 1. If the patient is maybe aged, I will go to R2. So as you said, age, gender play an important factor. Mm-hmm. Thank you so much.
Yes. Thank you so much for that in this comment. Very good. This is the same thing I do. If I scramble the photos, the same thing, you think the more attractive exposure is something about 1.5 and 3 millimeters. And most of people would choose this kind of exposure. So here we have another thing that we have to choose when we're going to do our treatment planning. Is it to match this kind of exposure? I think so, and I'm going to show to you some cases that I treated with this thing in mind. Another thing, the step between the central incisors and lateral incisors. This is something important, and this is something that's related to attractiveness. And we know that female more than male want to have the step bigger than female want to have the step bigger than male. And here we have some examples of this. We have those fine, beautiful women showing this step, even though they don't have straight teeth. In some cases, they have this step between central and lateral incisors. Here we have males showing more or less step. And we, as orthodontists, can change this since the beginning when we choose how to put our braces on. So this is the way we do things in orthodontics. We put our braces, we bond, this is the bonding phase. We can put our braces, showing these incisors, the amount of exposure we want. We can do this even if we fail doing this in the beginning, we can do it later. I'm going to show you with bands. with extrusion bands, for example. But in the beginning, we can do this. We can do more cervical position in the central incisor and more incisional positioning of the lateral incisors. So during the alignment and leveling, we will have the step that we want naturally going with the sequence of wire that we put in our patients. So this is something that we have to show to our patient. What kind of a step do you want? Here in Brazil, we have a very famous actress. It's called, she's not an actress actually, she's more than, she presents shows. She's called Xuxa, and she has this huge step between the central and lateral incisors. And we have sometimes people in our offices asking for having this kind of exposure like Xuxa. She has like 4 millimeters of this step, and people think it's beautiful, it's attractive. As we know, we are, sometimes we see actors and actors, and we want to have that kind of looking, that kind of good looking, and that kind of smile. So it's common for here, for people here in Brazil to ask for the Xuxa step, as we call. So we can have the zero. Some people, some male especially, want the zero, no step between central and lateral incisors, have half a millimeter, more than 1 millimeter, and more than that. And we have to put in our mind, so the relation between the step and the exposure to have to mix all together in order to have the best treatment planning. So less or more exposure is something that we can do and something that we can ask to our patients. Mo, again, do you like huge steps? Or same thing for men and women that you said. It depends on if it's men and women, male or female, and the age. The same thing here?
Okay, so if the patient is female, I would love to see this one the most. I'm going to highlight it now. Let's look.
This one? This one?
Yeah.
Or this one? Something like between this and this?
This is very interesting. It depends also on the race, and not only the race, actually, where are you based? So Mark is a white Caucasian, but he's practicing now in South Africa, and he's not exposed to Brazilian or the maybe his perception is different. So again, this is a very good point. Yeah.
Yes, you're completely right. And we have some papers that are discussing this kind of thing that you've mentioned, the race thing. Yes, between, for example, the nasolabial angle, Afro-American people who live in the United States and Africa, they tend to choose different nasolabial angles. The same thing, I completely agree with you. But the most important topic for me here is that you need to ask your patient for his or her preferences. Don't you agree with that? For instance, yes, this case here, this is a patient of mine, and that during treatment, I had this asymmetric step that you can see. I failed in the positioning of the brackets. So in this situation here, I asked her, what does she think about the step? Which one would she prefer? The right, her right or her left step? So she told me that she would prefer the right step. So this one here. And doing this, I made this kind of band here in order to correct the step that she wanted to have. So I asked her before, and she told me that she would like the step, and I did it because she asked me for. Another thing that is important is of course, we know that the gingival exposure, and some people don't like at all to have gingival exposure and consider that a failure, flaw in the smile. But I do not. I really love gingival exposure, and I offer that to my patients. I would like to have more gingival exposure during the smile, and I explained this for them. And some of them I don't like at all. And other, they like and they want to have this exposure. And another thing important, the gingival margin height, the zenith height, we can manage this too during our bonding phase in orthodontics. And this is something that we know that is important to keep in mind. Let me move on. Let me move on. For example, this situation here. We have one of those two teeth here with more wear in the incisor edge than the other one, and we had to decide which one do we prefer in order to put the gingival margin in the same height. We would like to put this one here, the tooth 21 or the 11. So this is something that is important for us to decide at the beginning too, because it is related to the periodontal status of this patient. If he had a pocket in this, a pocket depth, higher pocket depth here, I would like to do the incision here to have the same height, but in this case he didn't. So what we did here is to choose the higher position of this incisor to put the bracket in position. So what we do in this kind of situation is to assess the difference in height and to put our brackets accordingly. And this is what we do since the beginning, and we do this difference in the bracket height in order to compensate the gingival height. So during the alignment and leveling, we can do this correction softly and nicely. And then we can do more correction with bands, as we will see from now on, okay? So during the bond phase, we just have to keep in mind our treatment planning and our goals in order to achieve, at the end of treatment, our best smile for that patient. Okay, having in mind the height, the gingival height, the exposure, the step, so that we call the microaesthetics that we have to choose. So this is what we did here and what we do in this kind of situations that you're seeing. Again, here's at the end of treatment, and now showing the stability of this positioning. Of course, this patient did this composed in the left incisor after that, and here before and after treatment. Another thing that we choose when we are going to do our treatment planning is in cases like this one, for example, we have lateral incisor agenesis. This patient had this agenesis. In this case, we chose to close the space. As you can see, it's easier for me here to close the space than opening the space in order to put implants on the lateral incisor. And I know that many people say, no, it's not possible. I'd like to put the implants on the lateral incisor because with time, this premolar can show erosion, can show other things. But as I told you before, this is something that we do based on our experience and science and what we believe. So I'd like to do this kind of thing. If she were my daughter, someone related to me, I would do something like this. I would close this space. So this is something that we usually do in situations like this. And here is the occlusion view of her occlusion. And here, this thing that I want to call the attention for. This is the height that we put the bracket here, and we put the bracket upside down. This is something that we do. Of course, it depends on the prescription you are using. In my prescription, for example, we have 7 degrees of positive of negative torque on the canine, so I put it upside down to invert the torque from negative to positive to resemble the lateral incisor. So in this case, we put the bracket upside down, and it was bonded more cervically, more towards cervical. So it could be possible to do the extrusion during the leveling and alignment phase of the treatment. So here we have this patient in this phase of treatment. Then here, for you to see the bracket, it's a canine bracket here, upside down. And we can do, of course, more or less angulation during the bonding phase. So we can still a little bit of angulation of this bracket if we want, putting it more angulated.
Gregor, can I stop you here? Yes, today you posted an amazing post, and you was talking about the effect of the vertical positioning of brackets on the torque expression. The more gingival you go, the more buccal root torque you will get. The more incisal you go, the more palatal root torque you will get. So in this case, you are placing your bracket more gingival or just in the middle?
More gingival. And as you can see, it will help to have the torque, the buckle torque of the crown, because it goes more gingival. So this helps us in this kind of resembling the canine to a lateral incisor, because as we see, as we know, the canine has a thicker root. And if we can put this root more inside that region, is good for us to do this kind of masking the position of the canine, you know? Do you agree with this?
Point. Yeah, very good point. So literally putting the bracket more gingivally for the purpose of bringing the gingiva down will also help you to put the root more
yes, inside the bone,
which is two in one. Thank you so much.
Yes. It's a win-win game. Yes. So we have here the lateral incisor, as we can call it now, as lateral incisor, because he's in this position. And other thing that we have to keep in mind is that we have to put the tube of the molars, a different tube than the first one tube. This is the tube that has zero angulation, because we are going to finish this case, as you all know, in a class 2 position, in a class 2 molar situation, because we're having just extraction, just abscess in the upper arch and not in the lower arch. So we're not going to finish it in the class 1 molar relationship. So in order to avoid an interference between the distal cusp of this molar, when you put a tube that's angulated approximately 5 to 10 degrees, we put a tube that has zero angulation and zero rotation. So this is a class 2 tube. This is something that you have to keep in mind also, because if you do not do that, we won't have this fine settlement of the mesial cusp of the first molar in this position here. So going on with the alignment, here I'm rotating the premolar that's going mesially, so towards mesial. And here is the finishing of the treatment, the finishing phase of the treatment. And now we have the treatment finished in one little bit of an open space there that I fixed with retainers. And here we have the case in the end and showing the exposure of these lateral incisors that are almost the canines in position lateral incisor are almost perfectly resembling the lateral incisor. Okay, and this is the position. This is the smile of this patient. Here we have her profile showing that she still has a good profile. And if you don't have the opportunity to do that at the beginning of the treatment, this is a case that a patient that sought treatment with me, having a lateral incisor extremely resorbed, and I had to choose between keeping them or doing this replacement for the canines for the lateral incisor. What did I do in this situation? This patient had a class 2, so for me that was not debatable. I'd have to extract those lateral incisors and close the space, putting the canine in position of lateral incisor and the premolar on the position of the canine. So that's what I did. And here we have how he came to me for this situation that you see. And I went on doing the leveling and alignment. And after that, I did the extraction of the lateral incisors. And here you see that I failed putting the right bracket, the bracket upside down. This is something I didn't do because at the beginning I used the same brackets that he came to me. So I decided to keep these brackets. And we went on, and this is the lateral incisor after the extraction. Do you want to ask something, Mo?
No, it was just an error. Okay. Thank you.
Okay. So here, the extraction of those teeth, and here put the crown position for its aesthetic purpose, and here closing the space, and in another time, closing the space here. And now we remove the crowns, as you can see. So we can close the finishing this finishing phase. So as you saw, I didn't change the bracket of the K9 in this situation. So I had to do this soft extrusion bands here, as you can see. So we put the gingival margin lower than the central incisor in order to resemble a lateral incisor. So that's what we did here in this phase of the treatment. And here you can see, and the torque, of course, that I'm going to show you later, and the individual torque, and here the position of the central incisor related to the lateral incisor. So you can do it later if you want to. So going a little bit ahead of our presentation, I'm going to show you the bands that I usually do during my treatment, in my treatment phase. Okay, first order bands, as you know, are those bands that are made in the horizontal aspect of the arch wire. And we here have two bands that I'm going to tell you in details about them. So we have many bands that are possible to do in sets, offsets. You can call it step in, step out band. Here in Brazil, we call it insets and offsets, same thing. You can do this for settling the lateral incisor when they are not that thick, when they are thin lateral incisor, because during the alignment and leveling, they might go like with torque, they might go inclining for buccally, and we can do this kind of bands here in order to settle the position of these laterals. It's very common, and we do it very, very, very commonly in our practice. And this is how I do this kind of band. Most people ask me, do you use that kind of plier to do this band? Because there are specific pliers for that fancy pliers. Actually, I've been presented with many pliers to use in my practice, because as a professor, it's common here in Brazil that some companies give out this kind of presents for us, this kind of gifts for us. But I don't use them, because I like to have the control of the amount of the band that I want to make. I know that we have 0.5 millimeters, 1 millimeter, 1.5. I know that it's possible, but I like to have it in my control, in my hands. So I do this with bird beak. Here we have the 139 plier, or bird beak, or jarabá. Some people call it different names. So what I say to my students is, because I know it's difficult for them to understand the position of the band. It's very common for them to mix the position when they do the band. So I always tell them, so start putting your finger medial to the plier and think in the medial position, what do you want to do with the band? Do you want to do an in band or out band? If you want to do in, you put the plier and you apply force medial to the plier inwards. So this is what I tell them in order them to understand the thinking that I apply when I'm doing this kind of band. Now I'm going off, first in. Now I'm changing the position of my finger to the distal aspect of the plier, and I apply force in the opposite direction that I applied first. So I go now forward. And here is the video for you to see how I do it. Without changing the position of the plier, I go inwards in this position medial, outwards distal to the plier. So I have this soft band that I can make. And if I want to make more bands with more angle, I can use another part of the plier, which is thicker, and I can make more acute bands. And here I'm going back to the position of the wire in order for the wire to have the right the right position, and I put it in place. And here I'm going outwards, medial, and inwards, distal. Okay? And here we have the band that we do. So it's necessary to preserve the original contour of the arch wire, because if you do not do this, if this part of the wire is more labial than this part of the wire, we're going to have here another band that we we would like, sometimes we want this band, but sometimes we do not. So if you don't want this band, you have to preserve the original contour, original contour of the arch wire. This is something that we do. And let me show you here again, this out now. If you want to do a step out band, is the opposite. First you go out, mesial, then you go in distal, okay? This is how we do the out and in this kind of band, having at the end this kind of band here, as you can see, okay? So this is, we call it the offset, you can call it the step out band, okay? And this is a band that I use frequently in my office because I see many times this rotated tooth that I have to correct, derotating it, and this is a very, very good tool for that. I use this Z-band, first order Z-band, frequently. And this is different from the band that we see previously, because here we do two bands in the same direction. First band here, and the second band, we do it the same direction. The trick here is to have an angle between the first and the second band. So this angle, this active angle, is what is going to correct, to derotate the tooth itself. So we have to have this angle here, as you can see, at the middle of the band, we have an angle which will go into correct the position of the tooth. You have to have this contour preserved in order to have the right band, because if you do not do this, you will have a different band, like the situation that I'm proposing here, in which you will have a inclination, a labial inclination of this tooth here. You don't want it. So always check your band. Always check of the right contour of the band. So here you have the explanation, the graphics of this explanation, showing how you have to do this kind of band to correct this rotated tooth, okay? Here we have it in this situation, okay? And here, a clinical situation where we used this kind of band. In this case here, we used, that is something that it's not very common, a night-eye wire, Sometimes it's difficult to control, I know that, but when we are already in the rectangular SS wire, it's very hard to do. It's very difficult, especially in sapphire brackets like this. So I use in this situation the night-eye wire, rectangular wire, in order to do the correction. And after that, I use the stainless steel wire to maintain this correction. Here you can see by the color of the wire that is a night-eye wire. Okay. Another view of this wire here. Again, an occlusion view already corrected. And here is how we do. The first thing that I do, if I can give you this advice, start with the band. Start tying the band to the bracket. It's pretty much easier to do this way. So you put in the position, this band, and you go there and you first start with it. I always use stainless steel ligatures to do this kind of band, this kind of force. I never use, in this situation, plastic ligatures. I use stainless steel ligatures for that. And here in the occlusal view, so we always start with the rotated tooth in order to correct it, and then we do the other teeth, put the ligatures in the other teeth. Okay, so this is put in the ligature, and after that we do it in the other teeth. So sometimes this is another solution for the case, Mo. This is another, I called it orthodontic solution. This is my the thing that I use in my presentation. Orthodontic solution. There are many orthodontic solutions. But I don't want to do this band because it's very difficult for me. What do you advise? What would you advise in order to avoid this band for me to do in this situation? You can do a free rotation, for example. In this case here, what did I do? I do an offset band, just in order to put the wire away from the bracket. And I use here a chain to rotate this tooth and this tooth here, okay? Repositioning the wire more mesial, which is important, an important thing too. And here we have it after just 1 month. So we have the tooth derotated, and now we have to keep it in position. So once you have it done, you have to keep it in position, because if you let it loose, it will rotate again. You have to wait at least 3 months in this position in order to have the renewal of the periodontal fibers and the bone growth around the root. So it's important for you to not to have a relapse of this rotation here. Okay?
Yeah,
so here we have.
This one should be monitored very closely, because if it's left for a very long time, even with the very light power chain elastic force, it might result in disaster. So
yes.
Yeah, so
yes,
not a very good option for the clock down, because maybe you can't see the patient for a long time. Yeah, so very nice idea. Yes.
Yes, even though we know, Mo, that we lose about 75% of force of these ligatures in just 2 weeks. So we won't have this heavy force applied to this tooth for the long period of, And this is something that is, for us, is good, of course, but of course, you're completely right. We have to be aware of that. If we don't go to see these patients in this lockdown, we may have a disaster. This is something that I'm always trying to explain to my patients. It's an emergency for me, because I'd like to see those cases running, what happens in 1 month, in 2 months, because if we just let them act, we may have really a disaster at the end. Okay, you're completely right. I wouldn't agree more than this. So this is what we have, the correction that we have. And what I advise to my students, Mo, is this here. For them to put the positioning of the canine more mesial during bonding. I don't know if you do that. Do you do this kind of trick?
Placing the canine bracket more mesial.
More mesial, yes.
Yeah. We call it canine tuck. And I think
tuck.
A huge discussion about it is good for positioning and also to support the lateral from collapsing as a result of relapse.
Yes.
I think, Mark, is it a Tweed philosophy originally?
Yes, it's from Tweed. That's true.
The interesting part about that is that many years ago, Bob Ricketts actually suggested the exact opposite. In other words, you bond the canine slightly distantly so that the mesial edge of the canine was slightly behind the lateral.
I think it's the other way.
Yeah,
the other way. But what do you think about it?
I remember listening to one speaker talk about that and say, you don't want that anymore. And he says, and the guy who said that, he's dead now.
So actually, let's take this opportunity and welcome the past president of South African Orthodontic Society. This is my fantastic friend, Sharat Karash. Gleber, let me introduce you to Sharat. He's a fantastic, more knowledgeable than Mark. No, they are both fantastic speakers. So welcome, Sharat, and we will be happy to have your comment during the presentation. Gleber, continue, please.
Thanks a lot for joining us. Here we have the positioning that we usually have, and it's more clear when we have a huge difference between thickness of the lateral incisor and the canine. So this is more important, and you have this outcome when you have this. So in order to prevent this, we can do this mesial position of the bracket, the mesial positioning of the bracket, in order to go outwards in the mesial and to have this soft alignment that we want to. So this is something that I always advise to my students. Of course, there are...
Fantastic tip. Thank you.
Okay, thank you very much. And moving on, second order bands. I'm sorry for having to do this kind of thing very fast because we have 2 hours. In 2 hours, it's very difficult for me to show many things, but I'm trying to do as soft as possible. I'm sorry. Second order bands are made in the vertical direction of the arch wires. And this is something that I do in surgical case a lot. I do when I go to the penile X-ray, when I do this, the rebonding phase, and I see things that I'm going to show you now. I usually do this kind of band. This is the second order band. This is how we do it. The aim here is to construct a band upwards, and then we do the angulation at the same thing as we do in the first order bands. But in the vertical direction, we have to generate here an angulation in the active part of the band, as I call it. So this is the thing we do. As you can see here, this part of the band is not parallel to the other part. We have an angle formed here, which is important for us to correct the position of angulation of those tooth that we want to correct. And we can do this band more soft, more hard, and we do it accordingly to the position of the tooth we want to change. So we go upwards again, and now we go in the opposite direction in order to have the parallelism between the mesial and the distal part of this arch wire. That is very, very important. This is what you want to see after doing this kind of band. It's very important to check this, because if you have here more up or down position of this part of the arch wire, you will have a step down or step up created here too. If you don't want it, you have to prevent it having this parallelism between the anterior and the posterior part of the arch wire. Okay? So here, okay, of course, keeping the parabolic format of the arch wire is very important too, because sometimes when we make this kind of bend here, we miss. If we don't grab the plier and the wire firmly, we can have a rotation of this part of the arch wire, and we may make a bend different than what we want to. Okay, so here it is, just a lateral view and a frontal view of the arch wire and the band that we constructed, that we made. And here is this important thing. Here the video, how I do. Again, I can either apply force to my finger, or I can just use my finger as something that I put force just in the I rotate my wrist and put in the finger just to support, or pressure to the finger. Both are possible, okay? And what is important here? To check this, the parallelism between the distal and mesial part of the arch wire. Before you put the band inside the slot, you have to understand that it's very important, because you don't want to do different bands than what you want to construct in order to correct what is wrong. So here we have the couple, we call here in Brazil binário, and here we have the position that we check before we insert the arch wire inside the slot. So as you can see here, we have this band that is made in this position. This is the angle that we generated here. And the posterior and anterior part of the arch wires, we have the parallelism. They are in the same line, so we don't do like up or downward bends. Okay? You want to ask something, Mo?
You are doing something similar to geometry 3 in this case.
Yes.
So you are doing the geometry 3 within the wire bending. Thank you so much.
Yes, that's it. That's it for straight wire appliances. We like to do this because it's practical, you know? It's easy to do.
Absolutely. And
okay.
I like the idea of ligating the adjacent teeth, because you don't want a reactionary force on the adjacent teeth and uroinus. This is very important things.
Yes. You want to isolate the movement that you want in this position here, so you can do this attachment of those teeth in order to keep them in position. So in this situation here, what I wanted to do is just to close this space. As we know, a tooth that is vertical, it occupies less space than when it's angled. And this is what we do. The patient, he or she doesn't want to have this composite in this part of the the anterior part of the arch wire, or their teeth, okay? So in order to close this space, we can do this. And there's another situation that is very common when you can do this too. In situation like this, for example, when you have the contact between the apex of two teeth, two roots in this situation, you'd like to put these two roots apart, one from each other. It's important for this, in order to have stability and to avoid resorption, of course. So you do this kind of band, this kind of second order band. I show this case here in my Instagram, and people ask, but why didn't you do that during the bonding phase? Actually, I did, but I missed the position. Sometimes you do mistakes, and when you see those mistakes, we can correct. And here, I'd like to call your attention for one point here. Many people would say, in this part of the treatment, I would like to rebond the brackets. Why do I do the bending first and then I rebond? Because when I do this, I can go forward in my arch sequences. In my arch sequence, if I am using now, for example, a 018 stainless steel arch wire, if I'm going to rebond that bracket, I'm gonna have to go back to a soft night tile arch wire to do this correction and do the sequence again. And in my opinion, this is not fair with your patient, because you keep doing the treatment, and this is not good for the treatment sequence, you know. In this case, for example, I had to go back into my arch wire sequence, as you can see here. But in this case, I put a A18 night tie arch wire. Oh, so this is okay. Sometimes you have to go back. It's normal. But there are other times that when you can go just do the rebonding after you correct the position of the tooth, and then you go and put and rebond it passively. Do you understand? Go the position, go the arch wire, straight arch wire, and put the bracket position without the need of doing other kinds of bends. This is something that a student of mine, a former student of mine, gave me, and a photograph. Unfortunately, it's not a good photograph here, but she showed me that I was correct. Kleber, you always said that we had to pay attention in the horizontal position of the arch wire, and she didn't. What happened here? An extrusion in this tooth here, because the arch wire was not in a parallel position, the medial and the posterior part of the arch wire. And she had this kind of bend. This is a situation that's very common for me, because I work in the two clinics that we have implantologists with us, and they always they would send me patients with this kind of treatment planning, opening the space for implants. So this is something that we know how to do. Here is how we do. And guys, what's happening here, that I put videos on my presentation, because last time that I presented here, I had a little trouble with this. The presentation was very big, and it was not that soft. So this is the video, and this is what happened after the tooth loss. And here is what we usually do. We apply those coil springs, compressed coil springs, in order to open the space. But as we know, we are putting a force away from the center of resistance of those teeth. And what happens is this angulation, okay? And in this situation, a good band to use is a Z-band, second order Z-band, in order to achieve enough space between roots to put the implant. And we know that we have to have at least 1.5 millimeters between the implant and the root in order to be safely position the implant. Here we have it. So after that, we open the space. And another thing that's good, this is beautiful in this case, is that we used this ridge here to grow both bone here, and we kept the beautiful amount of bone, thickness of bone in this position. So this is another way we apply the second order band. So to do to diverge the roots in order to put the implant in position. Another band, the intrusion extrusion band. Mo, we are here 1 hour after the start of the presentation. Do we want to stop to
I
do
think
some kind of
it's a
question?
good time. I think it's a good time to
Drink water.
drink water and collect some question. Actually, I was busy, looking at your face, and it's remind me of one of the actors, and I'm trying to search on the internet. I don't know if any actor I'm trying to find, but I will find it. I will find it. Sharad, how are you? Sharad, are you with us? Dr. Carla from South Africa, because your microphone is muted.
He's muted.
Do you have any question while I am gathering some questions from the audience?
No. I just admire the handiwork of Kleber there, and yeah, it's very good. I mean, it's something that's not taught a lot in universities nowadays. It's so much easier to just that if any student, you ask them, okay, just put a bend in there to upright or tip the tooth, they'd rather just reposition the bracket.
Absolutely.
Mm-hmm.
If you
But
ask,
I like
you ask them this, you have to give them maybe 10 wires at the same time. Mark, what's your opinion? Or let's start with this question. If tooth number 11 crown is acceptable, but the root on the OPG is bent severely mesially, so if the crown is acceptable, but the root is severely bent, this I will expect some dilation. Do you align the crown or the tooth? And why does this problem happen? This is a very good question.
Mm-hmm. Very good question. Okay.
Opinion. What do you think? Do you accept the crown or do you accept the roots?
You're asking me or Mark?
No, let's ask Mark. So you'll take some.
I mean, Mo, I think we've spoken about this before, about the column angle and things like that, haven't we?
But the column angle in labiopalatal, not in the mesodistal.
Yeah, but I mean, the point is that at the end of the treatment, you need an aesthetic result. So if you're going to actually be guided by the roots, you're not going to achieve that.
Yeah. So you can't achieve win-win. You have to accept a compromise in the root. I don't think this will be a problem because we look at unless it is adjacent to a missing tooth, then in this case you have to align the roots, then reshape the crown to some degree. What do you think, Prof. Kleber?
Well, about the question that I see here, what's important to think is about the position of the roots too. If the roots are in contact, you will have to apply force to the crown in order to take one apart of the other, because it's important to have not a relapse of the opening space on the crowns and the resorption. That's a very huge problem. So, and he asks too if why does this problem happen? Sometimes we put the brackets in a wrong position, or sometimes it's natural, the positioning of the groove, the root is very close to the other root, and we have to fix that, right?
Absolutely. Thank you so much. We have another question. When you apply first and second order band, always we are having a change in the torque. How do you manage that? I'm assuming that the person who's posted this question is referring on a band in a rectangular wire. And then the second question, how do you bend nickel titanium? We know that there is no difference between robot bending and cold bending of night-tie wire. So let's go to the first part of the question.
Okay. That's referring to this first part of the question, Mo. I'd like to answer this in a few slides ahead, because there's the slides, the presentation will have this explanation. So if I do this, I'm going to spoil the surprise.
Okay. Then what do you think about night-tie bending? Is this
but we try to do that in order to have a softer band in situation that we have to have, we need to have a huge difference in angulation. So we do that even though we know it's not precise. What we do is apply a very heavy force to the arch wire in order to do a plastic deformation, because it goes to this elastic clariform and then a plastic deformation, so it won't go back. But we know that the shape is not a very rigid shape, and it can change between sections of seeing the patient. Do you understand?
Yeah, very clear. Well, we have another question. It's very generic and basic at the same time, but advanced at the other time. So which wire you are going to use for this band? So let's make it, let's chunk the question. So which wire you prefer if you have a small or mild first order band issue? Let's say 1 to 2 millimeter.
Round wires. I started with round wires, and I repeat those bands in the next wire. So if I have to do a greater band, I do it in the next wire, doing the sequence as I told you. And when I have that correct, I check it by X-rays. I check it by X-rays, and if it is already correct, I rebond that tooth that I correct, putting a heavy arch wire in position and putting the bracket passively. Do you understand this?
Absolutely, absolutely clear.
Okay. This is what I do.
So what Glebar is using, if he has some order bend problem due to tooth morphology at the start, he will do some wire bending, okay, to correct the position, like in and out. And then because he don't want to replicate this every time, every minute, every visit, every wire, when he reached thick wire, he used the thick wire as a template to determine the amount of the sandwich of the composites underneath the bracket. So he's actually building first order band in the bracket.
You explained beautifully, much, much better than I did.
No, I'm learning from the master. So, Glebar, another question. What you will do usually to correct second order band? Which wire, which thickness, cross section and thickness? Thank you.
Again, this is the same problem. If I have slight corrections to do, I would do that with round wires. But there's a problem with second order bands doing the correction of the angulation, which is when you put this wire inside the slot, it tends to rotate. So sometimes you want to do one kind of correction and you get another. You get like a buccal flaring of the teeth, of the crown or lingual, because it rotates inside the slot when you have a huge band. So this might be a problem. So in this situation, I would prefer a rectangular wire for that.
Thank you so much. You know, Glebar, we are living in the life of everything fast. 6 month orthodontics, 3 months aligners, 2 days coronavirus, whatever you like. Okay? So I know that some orthodontists, and especially resident and junior orthodontists, they are very, very in hurry and impatient to express this band. So in your opinion, let's take the question in another, let's rephrase it in another way. What is the most important thing to get the result of this band? Of course, the amount of force and the space, availability of space. If you don't have a space, you'll not get it. So if you have tight contact, you will not get this order band, because some order bands might require space, especially if it is, a second order band.
Yes.
If you are converting the tooth from upright to tipped, you need a space. But
and the space you can gain. There's a space with labial inclination of those teeth. So if you don't have enough space, the same thing when you have crowding. If you don't have enough space and you put a night-eye arch wire, it goes labially inclining.
So can you give us a number, like how let's per 5 degree of second order band correction of the root, how long it will take? Just give us a figure, because people, they like numbers.
Numbers. Let's see. With this 5 degrees that you're proposing here, I would do this in like 2 bands. First band, softer band, lighter band, and the second band to correct the 1 month later. The patient comes to my office and I do the second band. Why do I do this? Because when you do a huge band the first time, you won't have movement. You have resorption, because you won't have you concentrate all that force that you are applying on the apex of the root. So this is something that you have to keep in mind. You don't want to have a hyalinization of the periodontal ligament. You have just a soft force in order to apply the force to the apex, and you have a good movement of the teeth or the tooth, and then you don't jeopardize the root a long time, you know?
Thank you so much. Very clear question, clear answer. This question for Sharad. Sharad, do you use a lot of utility arches?
No, I don't. It's only in mixed dentition stages I use a utility arch, but otherwise I don't.
Okay, so Gleber, can you share with us at some stage some videos or technique of bending utility arch and burst-in arch?
Right now?
Not now. Maybe sometime but this is something very basic. Everyone should know it. But maybe we can share videos.
Yes, I can share a video later on in the master group if you want. I have those videos. Okay.
That's good. We will. Let's see who raised his hand. If you have any question, guys, I'm more than happy to allow you to talk. Okay. So raise your hand now. Idona, go ahead, Idona. Okay, Idona, how are you? Hi, Idona, you need to unmute your microphone. Okay, this is a problem. Okay, Parth, go ahead, Parth. Okay, let's take another question. As you can see it on the screen. Yeah, Parth, are you okay? Can you talk?
Mo, if we don't have questions now, we can move on because we have many things to show. It's up to you, but I don't know if I have the time to do this.
Yeah, I agree with you. Let's answer this question. When we use these finishing bands on rectangular stainless steel wire at the finishing phase, first, I don't think that we use it in rectangular wire, in rectangular stainless steel. We found it's difficult to express the movements. What is your recommendation for the wire selection regarding the material and size? To use rectangular TMA or to go back to round wire and apply this band in all stage or something?
Yes, the rectangular TMA is a good option if you want to do this correction because, as we know, it's less stiff than the stainless steel, but it's not. I don't like the friction that the TMA generates when we do this kind of correction. So I usually do not use TMA. I use stainless steel, and I go to the round wires for that, and I go on and on. If I have to do it the rectangular wires, so I do again the rectangular wires. But I usually don't use TMA for that.
Okay, thank you so much.
For other things.
Okay, thank you so much, ladies and gentlemen. Please, can you help me? I will just make this for fun. Can you help me? Gleber, look like who? I think there is an actor. If I didn't remember it, I will die. Honestly. Can you please, the chat section now is open. Okay, so can you please tell me what look like who? Exactly. Sharad, you look like what?
No.
Pablo Escobar. No, not Pablo Escobar.
Pablo Escobar.
No, look like, yes, very true. Pamela Anderson, Adel Imam. Yes, you look like an Arabic actor. His name is Adel Imam. He's just a Sholay movie from Hindi movie. So you are like one of the Bollywood stars.
I'm going to Google it. I don't know this actress you mentioned now. I'm going to have to Google it.
No, I think you look like Escobar. So the stage is yours.
Thank you very much, my friend. Let's go. Let's move on.
And then the next will be Sharad. Don't worry. I will put you under the microscope and see who you look like. You look like someone like
where is my presentation? Oh my gosh. Okay. Can you see the presentation now, Mo?
Yes.
Is it in the screen?
Yeah,
okay.
Yeah, you can.
Okay. Let me see just one thing here. Okay. Okay.
Wait. Can I just 1 second? I remembered now.
Okay.
I remembered. I will share my screen. I told you I will die if I didn't know it. So this is how you look like. You look like this guy.
Yeah.
Who's this guy?
I don't know. I have no
Good.
idea.
I think. Oh my God. I don't know him.
Okay, sorry.
Let's move on.
Your screen
No,
again.
no, it's not high. Very good. So let's go to the other bands that we have here. So for refinement bands, we do a lot of step down, step up bands like you can see here. So those bands are very common in my office and my practice. This is something that I do in my day-to-day practice. Another way to use this kind of band is when you do the forced eruption in order to achieve more bone for putting, for example, implants or to enhance the bone position related to the tooth or the gingival position. And this is something that you use a lot with extrusion bands like the step down band. And let's see this case here. Oh, I'm sorry. I was wrong here. Let's see the video. This is the case, and let me show you this case here. This patient surgery treatment.
You need to share your screen, Kleber.
Isn't it now?
It was not
Sorry.
shared. Sorry, it was my fault.
No, my fault.
Yeah, go ahead.
Is
Well
it?
done. Yeah.
Is it? Oh, can you see it now?
Yeah.
Okay. Can you see it?
Yes.
Good. So this patient searched treatment for looking for this kind of correction here, and he had this huge loss, bone loss in this situation. And as you can see here, we managed to do this extrusion with the bone coming together, down together. So this is the way we do 5.5 millimeters each 10 days or so. And we do another 5.5 millimeters, and we go on and on, doing, of course, always this adjustment and the crown length. And we do that by bursts, and this is what we do. And all the time, every time patient comes to our office to do this band, this is something that can correct or can enhance the position of the root, or position of the bone, I'm sorry. And this, as you can see, it allows for a very, very beautiful correction of the gingival tooth, as you can see here. So it's done by the bands that we do in our office, and subsequently enhancing increasing the amount of the band, the size of the band, every time the patient comes to our office. But here, let me show just another case. This case here, I know many people wouldn't agree with the treatment plan that I gave him, but for me, it was a very good treatment plan because it achieved a very good outcome. As we will see, this patient suffered trauma against those incisors, and those incisors were lost. So before we did the extrusion, the extraction of those incisors, we did the slow extrusion of them. After going to the periodontal treatment, he came to us, he returned to us, and we did this kind of slow extrusion, forced eruption of those teeth. So this allowed us to gain bone in that region in order to close the space, putting lateral incisors in the place of the central incisors, canine in the place of lateral incisors, and premolars in the place of canines. So we went on closing the space, and when the root was the same size of the crown, we removed the root, the teeth, and then we closed the space, and after that, patient went to the compost, okay? So this is, it's a little bit fast because it's a video, I'm sorry for that, but just to explain how we always deal with this kind of band in our office. Here is the treatment going on, putting the line of action close to the center of resistance, and here the patient in this phase of treatment, which is not yet finished. We're going to have to correct some things here that are not completely right, but I think at the end of treatment, we achieved a very good result. And this patient, I told him, there's a possibility that you lose the lateral incisor that will be in place of central incisor, because, those teeth may not sustain that force that you apply to that region. So in the future, you may have to do implants. And he told me his answer killed all all those doubts that I might have had at that time. He told me, well, the first thing I came here is to put implants in these teeth. If in the future I lose those teeth, it will be okay, because I was already expecting to have implants in this part of the arch. And this is how he was, a class 2. So in this position, either going forward or backwards here, it will be a long treatment. So we decided to close the space, putting the posterior teeth forward. That's what we did, using bands for that. Sometimes it's much, much easier than this. For example, in this situation, we have this teeth here, the central incisor, where in the tip of, as you can see, and there was an extrusion of those teeth, putting the gingival margin at the same level of the lateral incisor. In our treatment plan, we wanted to do the intrusion of these margins, and since the beginning, as I told you, as I showed you in the beginning of this presentation, we did the intrusion, putting the brackets more incisively positioned, and here we have what we obtained in this situation. It's better now, but wasn't complete for me in my point of view. So we did the intrusion of those with bands. So here, as you can see, we have now a more favorable position of this gingival margin in comparison with lateral incisors and canines. So at the end of the treatment, patients were referred to the cosmetic dentistry, where he did the decomposed in this teeth. Okay, so here it's another way to correct, thinking about the intrusion extrusion bands, this kind of feature that we have sometimes. Okay, so here we have before and after treatment, showing a more static margin display between central and lateral incisors. And here's the trick that we have to keep in mind. This is concerned to that question that was made before, that about the wire that I used to do the correction, because we know it changed the torque. It's true, because we are applying force away of the center of resistance, and we may have this kind of situation. So if you are using a round wire for that, you have to incorporate in this round wire another kind of band. It is an out band for trying to resist this tendency towards lingual of the crown. So what we do when we do this step down band is to complete the band with a step out band, as you can see here in detail here, because it's expected that this tooth goes down and lingual and palatal. So we want to avoid that, and the way to avoid that is doing another band in round bands, in round wire bands. We do that. So as you can see here, we have to control every time the position of the upper arch against the lower arch. But if you want to do this with rectangular wires, you may have a different way to deal with this, which is, okay, you do the rectangular wire, and when you do the extrusion, somewhere during the extrusion, it will generate, because of the tendency of doing this kind of rotation of the crown, it will generate a couple inside this slot. It's because of the rectangular wire, of course. So in this situation, you may have more control of this situation, which is good. As you can see here, you do the extrusion, and during the extrusion, the couple emerge, and now you have the moment in the opposite direction, that moment generated by the force of extrusion. So it may have those moments are equal in some way, and they are erased somewhere. So this is something that is good for us. Of course it is, doing this kind of extrusion, but I see two problems here. First one, when you do that with rectangular wires, we tend to have a heavier force, which we may not want relating to the extrusion, slow extrusion. If you are doing a rapid extrusion, if you are doing that kind of extrusion that you want to do in order to take off the tooth from its socket, its bone socket. We use it sometime. You can do this with rectangular wires, but I don't like to do this when I do this low extrusion. The other problem that I see in this situation is that we not always have the right amount of inclination to put our rectangular wire passively, in a passive situation. So sometimes we may add moments, and this is very, very difficult to show, to explain to our students. So I always say, when you do the rectangular wire bands to do the extrusion, you have to be completely aware that you may generate two moments in the same direction. So like here, we have here one inclination of the crown, and we have an inclination of the slot that is completely different from the inclination of the arch wire, the section, the transverse section of the rectangular wire, and it will generate a moment in the same direction that will be generated by the extrusion, the moment generated by the extrusion. So we have the couple, and we have the moment of the extrusion generating the same situation, which is a very, very fast losing of the inclination of this tooth, okay? And as we see, we can do individual torques, of course we can do, but when we are doing this kind of band to extrude just one tooth, it's very difficult to control this torque in that section of the arch. So, in my opinion, in this kind of situation, you would better use a round wire. So, going on, sometimes we do this kind of extrusion in a whole section of the wire. This is something that we do sometimes in order to generate a more parallel exposure of the tip of the incisors. So sometimes you do in a whole section of the arch wire. This is something that we do when you want to do this kind of disclosure of teeth. Another band that we use is a second order band to intrude or to extrude in the posterior part of the arch wire, as we can see here. Sometimes when you do the bonding, we miss the position and we have the extrusion of the second molar. And sometimes what happens in accordance to this, like what happens when you do this is extrusion and opening of the bite, because the first tooth to touch is the second molar. So this is a band that we do it very commonly in the second molar in order to prevent or in order to correct the situation. So this is a second order band. And for that, we always advise our students to use in the first molar, even though if you're not going to put right now the tube on the second molar, you use for the first molar a convertible tube. A convertible tube is a tube that can be opened in order to put the wire from labial, okay? So if you have to do a band in this position, you don't want a closed tube. So in this situation, we choose almost always the convertible tube for the first molar, and we do our band after that. So this is how we do. We check the horizontal position of the band, and here we have the band in our typodont, in our model, orthodontic model, and this is a clinical situation where we did these bands, as you can see now, just in order to do this refinement. Okay. And this is probably the easiest band that I'm teaching you today, that I'm showing you today. I'm not teaching, I'm showing you today. And this is how we do. I'm sorry, this is already the second possibility that I'm going to show to you. This is actually a L loop that we use in order to replace this intrusion band that I used before. And this is how we do this loop. I'm going to show it in a few moments for you how it works. Here, finishing this loop, this L loop made in the arch wire itself, and here is how we see if it is passive, if it is parallel or not. So here we have it in a situation where we used it. So in this case, this patient presented this asymmetrical displacement of posterior teeth, and this case was it happened because she had this crossbite, and we did this elastics to correct the crossbite, but it was not completely correct on the second molar. Then we did that band. How this band work now? We activate this band in this situation here that you see, putting the end of the band more to lingual than the other part of the arch wire. So it is active. It's an active band. So in this situation, I did, and this is the explanation in this graphic how we do this kind of band. Okay, in this case here, let me check it out. In this case here, there are two ways to do the band. You can do it either towards mesial or towards distal, the L band. But when you are going to intrude, this is something very important that you have to keep in mind, because the arch wire, it may be more effective. This band is more effective when it works closing the loop. So this is the situation they're proposing here. Once we're going to intrude this tooth, when you go to put the arch wire inside that tube, there is a tendency towards closing the loop, which is more effective than opening. So in the situation, making this kind of bend towards mesial is more effective than doing it towards distal. Okay, and this is what we have when we do this kind of correction. And sometimes we are able to close a bite just doing this. Okay, so this is how it is active. We can do it either for buccal or lingual activation. You can do both. Okay, this is how we do. And in this situation, obviously, it was activated towards lingual, not buccal. Okay, and here is to see the correction of this in this kind of case. Okay, and just going on with the video, you'll see the end of treatment and the outcome we had, and the smile, what happened with this smile. Pretty much better smile, more symmetric, showing more teeth in the posterior left portion of the arch. Another loop that we use, a simple loop for those stubborn anterior teeth that are rotated, and we can't manage to do this with the night eye. So this is simple to do, and we can either do this passively or actively. In this situation here, for example, it's activated in order to do like a first order Z band. As you can see, it's almost the same thing, but we have more flexibility in this case. So the situation where I use this kind of band here is when I want more flexibility. As you know, the interbract distance here is very, very short. So when you put bands like a first order Z band, you might generate a huge force here, which you want to happen. So this is a way to overcome this kind of bad outcome that is possible in this situation. So here it is, the correction in this situation. As my friend Mo said before, sometimes you have to do the IPR because you don't have enough space for that, or the derotation of these teeth, and we do the IPR and have the correction, as you can see, very fast. Okay, here we have. Sometimes you have to do the activation more than once in order to achieve the best position of this tooth. This is pre and post activated and post correction. Okay, pre and post correction, and we can see here how soft alignment that we have in this situation here. Okay, you can say now I might try to put the bracket more mesial in this position, and then I go with an arch wire, a softer arch wire, a night eye arch wire. Yes, it is possible. I'm just showing you another tool for doing this. Okay, this is how I do in most of the cases where I have those stubborn lateral incisor that don't want to get into the arch wire. This is how we do this kind of bands. It's easier. It's easy. Again, I use always one plier, just the bird beak. Give me the bird beak, give me the wires, and I do orthodontics everywhere. I just love this plier. Here it is, the finishing the band, the loop, and here it is activated, as you can see, with the mesial portion of the arch wire more labial than the distal portion, which is lingual, more lingual. It is active. Okay, this is another situation. Again, open the space. Now I want to do the rotation of this tooth, and I used for that this band. Here, here, first activation, the result of the first activation, a little bit of IPR here, and the second activation in order to finish the correction, and the patient came back 2 months, and we have this outcome here. Sometimes we see in our social media, people say, why didn't you use the Invisalign to correct that? It's very good to use Invisalign. I love Invisalign. I love aligners, but this is another tool. Just this, people, another tool that you can use if you don't want, if your patient don't want to use aligners or don't have enough money to do the aligners. I don't know, but it's something that you can correct very fast with the right force, okay? So the third band that we use in orthodontics is the third order bands, the torquing. And as it was said before, people nowadays don't want to do torque anymore. They want to buy a prescription and go with that prescription till the beginning to the end of the treatment, since the beginning to the end of the treatment, and they think that they can do that in every patient. So patients class 2, we use prescription 2, class 3, we use prescription class 3. So, but we have to understand our prescription, first of all. What kind of prescription are you working with? Do you work with a prescription that is for finishing, or do you work with a prescription that is made for movement? First question. And other question, when you are going to do the retraction of those patients, do you think that prescription is enough? Is enough to go against the tendency of losing that inclination that you want to maintain, to keep? So those are questions that you have to keep in mind. So my answer for my patients, my answer for my students when they ask me, can I just buy a prescription and work with that prescription for class 2s and 3s? And that's all. Why do I have to work with torque, Kleber? Because torque is difficult. Yes, I understand that torque is difficult. But the first day of my classes in the specialization course, I tell my students, we think edgewise, but treat with soft wire brackets. It's the most important thing. We think edgewise and treat with straight wire brackets. Because we have to understand that sometimes we have to apply torque, we have to apply bands, and sometimes straight wire can be disastrous for our treatments. So this is the tools that you have to have in our armamentarium in order to have the best treatment to achieve for your patients, okay? Torque. Torque is very good. Torque is beautiful. We do many things with torque. We was taught by Engel that it was, and especially Tweed, that applied those thinking of Engel to do the mechanics that we use nowadays. And we do torque every time. We do have to understand the relationship between when you're going to put a rectangular wire inside a rectangular slot, we have to understand the relationship that there is between those two structures. And pre-adjust the plies, they just want you to understand that you have a smoother tool to do less bends, but not to eliminate the bends. Not to eliminate them, because they are made for us to do a more, let's say, active treatment, more with less chair time. This is important for us, but we have to understand this.
I don't know if you remember what Andrew said. He said that the straight wire is like a plane. It will take you from Sao Paulo to London, but you have to have a taxi and you have to walk to your house. Exactly.
My friend, you're reading my mind. Let me show to you what's going on now. Exactly what you said. Huh? So if you go on a long journey, you don't walk all the way. You fly most of the way, then you take a taxi, and then walk the final 100 yards. That's exactly what you said.
Actually, now taxi you can't take it because of the social distancing. So you have to do a lot of walking.
That's it. You're right. So this is what was the first idea of Andrews. He didn't want us to just use straight wire from the beginning to the end without the need of doing some kind of bend, some kind of adjustment. So what are the adjustments that we have to do at the end of the treatment? The walk the final 100 yards. I don't know if you are seeing this kind of situations nowadays, but it's very common that you see people using aligners, and at the end of the treatment, they don't have that soft refinement. Sometimes, I'm not saying it's a law, but sometimes they don't have that soft refinement. And they just say, no, the patient didn't want to go on and on and on, and so I removed the brackets. Okay, or I removed the appliance. Okay, but if you want to do this refinement, you have to work with torques, we have to understand torques, and you have to work with bands. It's unavoidable. Absolutely. It's not... Absolutely. Yes, that's it. That's what I think. So you have many, nowadays you have many prescriptions that you can use, and they will facilitate your journey. That's true. Okay. This is another word, phrase from William Prophet, Bill Prophet. I find the precise details of the prescription moderately irrelevant because I know I'm going to have to make some adjustments for the specific patient in almost every case. Okay, it's another way to see things. I think it's relevant. I do like prescriptions. I do understand prescriptions, but I work with just one prescription, which is Andrews. Just it. Since the beginning, my orthodontic practice, I use Andrews. I don't have other prescriptions in my office. And I respect those who have. But I don't need them because I think edgewise working in straight wire appliances. Because I am the master of my mechanics. And this is what I teach to my students. You have to master your mechanics. And the way to do this is to understand bonding, understand bends, torques, and loops in orthodontics. Unfortunately, we won't have time today to show many loops for retraction and things like that, but I use it a lot, okay? This is just in order to understand what we think when we apply torques. We have the real torque and we have the relative torque. The real torque, the torque that is present on the wire, that can be neutral, that can be labial or lingual, and the relative torque is the relationship between the arch wire and the slot inclination. So let's see in details. In this situation here, for example, we have a neutral torque. When it goes inside the slot, the real torque is neutral, and the relative torque will be passive for that. We use I don't know, do you call it 142 plier in your country, this kind of plier here?
This is De La Rosa or a tweed?
Tweed.
Yeah, we call it tweed.
Tweed plier. Okay. Yeah. So we use tweed pliers for that.
The plier.
Tweed torque and apply. Same thing here. Almost the same thing. So we use it for checking the torques, for applying the torques, and for adjusting it. So this is the plier that we use.
It's funny. The reason why I stopped using the number is because we have 69, the birth peak. And one day I was telling the nurse, can you give me the 69 so the patient understands it another way. So this way, because it's misused.
My gosh.
Yeah.
Good. So let's see the prescriptions. Why do we have prescriptions? We have prescriptions to facilitate our daily practice, not to avoid doing things like bands and torques. So in edgewise prescription, when you go to the first arch wire, first rectangular arch wire, since the beginning you have to apply torque, because if the teeth are well positioned, they are in a labial inclination, since the beginning you have to do this. But what we are going to do, what we do when we do the prescription thinking, is that we have mostly the base of these brackets, we have this inclination embedded already in the space of this teeth. So this is something that helps us. Of course it is, because I don't have to apply, in most situations, I don't have to apply torque to the first rectangular wires. I can, it's less time consuming for me use the straight wire brackets than edgewise brackets. But I know that I have to apply torque. I know that because we have many variables between the situation that we have, that you see in the inclination of the teeth, and the plies that you are using, and the wire that you are using. So let's just say some of them. Let's just show some of them. For example,
resident, please take picture for this slide if you don't mind. This is the most important question that will come in the exam, and it's really, really important. Really good slide. Go and take picture if you don't mind, Kleber. This is very important. Thank you.
Okay, and if you allow me, Mo, I can send you this presentation showing the clearance of the play that you have between the slot and the wire, and showing this kind of things. If you allow me, I can send it to you so we can send to your students. Okay.
There is one thing that you missed: honesty.
Okay.
In this honesty. Most of the company, they give you a slot. They tell you it is not 22, 28, but actually it's 24, 30.
Yes.
And the reason for that is because they want to tell you that you can reach 1925 stainless steel wire very quickly. And actually you are not reaching 1925 stainless steel very quickly, but the slot is big. So
Yes.
Honesty, or they give you as wire, which is smaller than what is prescribed.
Smaller, precisely, yeah.
Honesty is another reason.
Yeah. Yes, you're absolutely right. I agree with you 100%. So this is something that there is. The companies do different wire slots and bracket slots and wires, and we have to understand that too. Okay, so let's move on. Yes, here we have an example of what's going to happen when you do the retraction, for example, of anterior teeth using a 017 for 025 in a slot 030 for 022, you will have a loss of inclination. You'll have a loss of if you have a good inclination, this will not happen at the end of the retraction, because you have this play between the slot and the arch wire. So this is what will go to happen. This is what's going to happen. You will lose some inclination because you'll have this. This is what's going on in this situation. You can have more than the 20 degrees that is expected, because what my friend Mo said before, because you have wider slots than you think you have. So you may have more than 20 degrees of loss of inclination during the retraction phase, for example. So this clearance your play between the arch wire and the slot, you have to keep in mind. If you're going to do very big retractions, oh my friend, don't rely on the bracket. Please, you will not be succeed at the end of the treatment. So think of it. Think of the relationship between the arch wire, and the slot height, especially the slot height. So this is what we have, and we have 19 in this situation. So we will lose a little bit less inclination because we will establish first earlier the couple that is generated here. So this is important for you to have in mind. So, but what do we do once, since we lose it? We're going to do the retraction. We have this situation. What can we do? If we do not know torque, for example, if we do not know how to apply torque, I know what some people do. The IPR on the lower arch, almost always, because they want to have the clearance between upper and lower incisor, and they don't know how to do the torque. So they end up with a very, very negative inclination of upper and lower incisors, which is horrible for the smile. So what happens is we have to stop our retraction. We have to do the correction of the torque, and the 3 T's of the torque applies always. Torque takes time. Don't try to rush. Do it and wait 2, 3, 4 months in order to have this correction, okay? So this is how we do, and after that, we can go on with our talk. Some people say, why don't you use a high hook for that? Sometimes we use high hooks for that, but again, we have the relationship between the arch wire and the slot. So same thing here. We have here the same situation. In the situation proposed here, we have the extraction of the first premolar, upper premolars, did a retraction, and we lose the inclination. So the same way here, we didn't correct already here this relationship here between canines, so we have to correct with torques. And this is the way I apply torque. There are many ways to apply torque, actually. I do this way because I think I have more control in my hand than doing it in just one way, like pulling up the legs of the arch wire. I do it like doing little twists on the anterior part of the arch wire and generating what Andrews called the wagon wheel situation. And this is how I apply the torque, and this is how I check the torque. We grab the arch wire in this anterior part, and we see how the arch wire goes in the posterior part, or go like this. This is something that we do. We grab and see it is a labial real torque, and this is how we're going to see the relationship here. This is active torque, as you can see, because when you go down here to pull the arch wire inside the tube, you're going to generate in this position a couple that is going to go flare labially stiff in order to correct prior to continue to resume the retraction. So this is what we do in this kind of situation. But what if I don't want at all? Mo, let me ask you something. We are here, Tim, for 10 minutes. Can I go just a little bit further than that?
Go as much as you want. We are enjoying it, and we like it. So those who are in a hurry, they can excuse themselves and leave, but we want to stay with you until the morning. So tell Manuela. Okay. Manuela that she...
Manuela?
Yeah.
Yes. Thanks. So let's move on. But what if you don't want at all to do a torque? I know I want to rely on my brackets, and this is what I like to do. So what I propose to my students is this situation here. You can use a full size bracket, full size wire inside the slot in order to have a rigid body. So you can use now this in this context here. You can use the high position of the line of action to match the position of the 6 or 8 or whatever you want to do the retraction. So you match the position, or you try to do this, of course, and you don't need to do this wire, this complete set of wire. You can cut it here because now you're doing here, the right position that you have to think now is the line of action that it's here, because inside this slot you have a stiff arch wire that's almost completely filling the slot volume. So in this situation that I'm going to show you now, it is possible not to apply the torque. But for that, you have to understand that you're going to use the finishing prescription bracket, because you can't use the prescription for movement because they have a higher torques. You have to have the final torque that you want in this situation. Here it is, so we can apply the 2130 arch wire in this bracket. So that's how we did in this case here. Okay, and for finishing with loops that I love to use. And this is the way that you can do if you want not to use torque in your brackets to do the retraction. It's possible. You have many tools. Again, we're working to increase the amount of tools that you apply to your patients. Okay. This is why our great friend here, Mo, is doing these webinars, to give you more options.
It's a tool in the box, as Mark said. It's always tool in the box. Maybe it's different from what you are doing, but it's tool in the box.
Yes. That's it. So let's see another way to do the refinement using the torque thinking, okay? Situations like this, for example, when you have a block the lateral incisor in palatal position. Then you do the opening of space, and you engage that bracket to the arch wire and go forward with that tooth. So it goes to its position, but you end up with this situation here. Okay, let me show in more detail here. So we'll have a more inclined crown that you want to have. So what do we do in this situation? Oh, many people say, I would just do they invert the position of the bracket because I'm going to have now a negative crown torque when I do this inversion. Okay, it's possible. I understand that. I sometimes apply that thinking. But what is more important for you? You have to individualize your treatment. So this is what we do. We apply the torque that is necessary for each patient. We don't rely just on the torque that is inside the prescription, embed on the slot. So this is how we do. We do the torque. We apply the torque, more torque or less torque. It's up to us. We do this. So that's how we do. That's how I do. I use these two pliers to do this. The female and male individual torque pliers. Again, I'm bad with numbers. I don't know what the numbers of these pliers are. I don't know. Do you know? Can you help me, Mo?
I use either you can eyeball it, or what do you mean by number of what? Amount of torque?
No, the number of the wire, because we call in Brazil we used to call the pliers by numbers. The 139.
We call them male and female pliers, or you have male and female key. If the male is
yes, I know the key. You can either use the two pliers or one plier and a key. Is that the same?
Yeah.
Yes, that's possible too. So here we have what we use in a clinical case. So in this situation here, we have a good position, was finishing the case now with the refinement. And what I saw was this situation here. It was a little bit more inclined than I would like it to be. So I applied the individual torque, as you can see it here. I applied the individual torque for this situation. Okay. And here, put it in position. Once you go to do this kind of insertion of the arch wire with the individual torque inside the slot, you have to say your prayers, because if you're using this kind of bracket, sometimes it breaks and it goes direction your eye. So it's not that easy to do. If you are using this kind of slot, this kind of bracket here, I recommend that you use very, very slight torque each time the patient come back, or you just change it for metal brackets, okay? So this is how we see the torque. As you can see here, it is torqued inside the slot. And here are the marks of the torque that you see where we applied with the male and female individual torque pliers. And here before, and we can see it now after the correction. So just details, but they make the difference, in my opinion. So once we aim perfection, you go to the best position you can. I know sometimes we can't do this. For example, this is one question that I always make to my students. Do we always seek the 6 keys of occlusion? Of course not, because there are patients that we cannot achieve the 6 keys of occlusion in some kind of patient, like patient with periodontal disease, patient with losses, but we can't. Where we can achieve the 6 keys, we have to aim for that.
Well, actually, this is very, very important point. I think as a well-trained orthodontist, we have to give the patient what he deserves, the 6 Andrews keys, unless there is another issue like perio issue or time or risk. And this is how we are differentiated from general dentists doing ortho, because we are giving an exceptional result. Thank you.
Yes, that's it. I agree with you. This is another situation that's common, to have to apply torque, individual torque. For example, when you do the traction of canines that are palatally blocked. So we do the traction of those canines and they come like this. with wrong inclination of the crown and the root. So in this situation, again, we have to do this individual torque in order to correct the bad inclination of that tooth. So this is common. They come to their position, and this is the clinical example of this. So they come from palatal towards labial. They come with the crown very inclined. So after doing this, if you want to correct, and I think you will want to correct the patient, because patients say that's not beautiful, and I know that, and you do this kind of individual torque, like you see here. This is how I teach my students how they have to think about the position of each plier. So here's the couple inside this lock and the correction that we got with this kind of use, okay? And here is pre and post treatment regarding this kind of correction. So as you can see, you have a nice inclination of the crown and on this situation. Okay, so my friend, I think that's it.
Very nice. Well, a small comment about the torque, because if you are using a torquing plier or torquing key, you always have the male from inside, from the inner part of the arch. So I always say that for you, in order to remember where the root will be, just remember that the roots has a sexual problem, and always follow the male. So always the root will go with the male.
I loved it. I'm going to apply my next
Very masculine,
classes.
very masculine. Yeah.
You're on shaky ground now, brother. You're on shaky ground now.
Everything has been. Thank you so much for the amazing presentation. Shall I share my screen now?
Yes, please.
Thank you. Okay, so I'm going now to share my screen. First of all, thank you so much for the amazing presentation, my friends. You know, I like your passion, and you are very passionate, and you are emotional when you go and present. This is something very important, and a lot of speakers they lack it, and this is really, really good. I'm sure that your students are very lucky. I just want to say something when you said torque take time, TTT. Okay, so absolutely. When we do retraction most of the time, okay, and we lose anchorage, this is what we'll get. We get pressure area and tension area, and in the tension area we'll develop immature bone. And then later on, we will be very excited to bring the root inside this immature bone. And usually this immature bone will take around 6 months to mature. And this is why torque will take time. So I totally agree with you. It's a very nice presentation. And I just find it now, finally. It's one of the cartel, Kali Carter. So you look like him. This is why I was. Where did I find? I remember I met with Escobar, and this guy was there. So this is why I.
Good.
Mark, do you have any question while I'm collecting some questions from the audience? So, ladies and gentlemen, you can go to the question and answer poll and shower us with your question. And here is Sharad joining us again, the specialist orthodontist from South Africa and the past president of South African Orthodontic Society. Both Mark and Sharad led the South African Orthodontic Society to huge success. So thank you so much.
Thank you.
Do you have any comment, Mark? We'll start with you.
No, you know, as I said, I think last time when Kleber spoke, you know, he's not only does he have the same favorite song as me, but he sings the same song as me with regard to his orthodontics. So,
Oh my God.
of this stuff.
I'm honored, my friend, because I know you are very well skilled orthodontist. You're very good orthodontist. Thank you very much for this compliment.
So then let's start with the first question. Thank you for the nice presentation, very informative. In case where you apply torque to the anterior group of teeth, how do you prevent loss of anchorage on the posterior teeth? Because, you know, we will get some anchorage loss, tipping of the molars. Do you run a class 2 elastic or something?
Oh, I use the anchorage that is needed for the case. For example, if I don't want to lose anchorage, I could apply those torque and using an indirect anchorage with mini screws or something like that to grab the molars in position. And I tie from the mini screw to the molar, I do the ligature, and I use the triagel in order to have more rigidity. And so if I want to lose anchorage, I simply let it go. And it depends on the case, I think, more. I don't use just one rule for all. It depends on the needs that I have to keep my anchorage or lose my anchorage.
Okay, thank you so much. Well, another question is the torquing key that you showed, very nice instruments. And I think the question here is to add a group of torque to the anterior teeth. I don't think that you can use it for multiple teeth, just for one single tooth.
So just for one single tooth, because for multiple teeth, I do the torque the way I showed before, in that video. You see, doing like a little twist of my wrist, doing this kind of torque in the anterior region with the tweed appliance, not that plier.
So you use the tweed appliers. Well, I'm going to just remove my background so you can see the mess behind me. And
wow!
I watched a video about adding anterior torque. And it's because if I use the virtual background, then you will not see it. So anyway, this is another technique. So this is my fidge. Okay, I'm not very religious, but I get it as a gift. So this is the arch wire. They put it in that way, like that. Okay, same like that. And then they hold it with the La Rosa plier and they twist it. And this will add a group of torque. And it is a progressive on the anterior teeth. I'm sure I will be able to share the video at some stage. Anyway, I will go back. So this is how beautiful now my
background.
Okay. Shara, do you have any comments? How do you add anterior torque to the teeth?
I use the tweed pliers.
On each of them.
Yeah.
So what about adding a reverse curve P? If you have a normal torque on the anterior teeth during space closure, you don't want to lose space. You add a reverse curve P in the upper anterior or exaggerated curve P in the upper, and then you start closing the space. So you build anti-torque. What do you think about this?
I sometimes do that too. Yeah.
Yeah. Okay. But I don't think that this is good for finishing. It's mainly for
retraction.
Yeah.
And remember, ladies and gentlemen, when you add the torque to the anterior teeth at the finishing, if it is a group of teeth, expect an increase in the overjet unless you support it with arch wire or you hold the teeth in their place. Otherwise, the crown will go forward. It's always easy for the crown to go forwards. I'm sure that you agree with me. So there is another question. Would you please show?
And most, just a second. In addition to that, what you said about the reverse curve P, I add another thing because when you do that, you increase the how do you say the friction. You increase the friction, and it's harder to do this closure. So I usually do not do that because of it, but it's a possibility. Yes, I've seen many beautiful cases treated this way, and it's definitely a possibility. But I don't use it because I think it goes slower than it has to go. I don't know if you agree with me.
Absolutely, totally agree with you. So what's your thought about bidimensional brackets to control anterior torque, which is 22 anteriorly, sorry, other way, 18 anteriorly, 22.
18 and 22, yes. Yeah. Let me say what I think about it. I've seen many cases treated with 18 brackets. I know that's many people like a lot to use this kind of bracket. What do I think? I think the 1730 wire is not stiff enough to prevent the collapse of the inclination. I usually don't use it because of it. So I do something different of that, but it kind of resembles this kind of thinking, which is I use 1930 in the anterior region, and then I trim the posterior region of the arch wire and I polish it so it loses its tips. I don't know how to say it. And so it goes more smoothly during the retraction. So with this, I have stiffness on the anterior region, control of the torque, and I have less friction in the posterior region. So what I'm saying, I like to work with 1930, not 18.
Thank you so much. If anyone want to raise any question, then you are most welcome to raise your hand, and I am happy to allow you to talk, but you have to check that your microphone is working well. Obrigado, gracias, amigo, for the brilliant, spot on, very important. You overlooked topic. This question is for me, actually. I'm planning to have an ortho treatment for myself, specifically to address this problem. I am in my early 30s, a female with no incisor show rest. However, I have a problem. Is that an OPG? Is that an OPG? I don't understand.
Anterior open. I don't know. I don't know what's OPG.
Okay.
I don't know what it stands for.
I think they didn't have enough space to complete the question. This is why it is cut off. So, Parth, you are unmuted. Go ahead. What's your question? Parth. Okay. Then let's go to Talat. Dr. Ning.
Hi. Yeah.
How are you? Where are you from?
Hello.
I'm from Malaysia.
Hi, nice to meet you.
Nice to meet you. Great presentation, Prof. Clever.
Tell me how they will say welcome in Malaysia. Let me remember that. First letter.
Selamat datang.
Selamat datang. Selamat datang.
Yes.
Okay. Selamat.
Yeah, absolutely. Yes. Prof. Clever, thank you for your presentation. It's really nice. May I know how do you add additional first or second order band on the same wire? Because you mentioned that we should do it incrementally.
Mm-hmm. Yes.
So how do you add on the second and the third time?
Yes. What I do is, I'm sorry. Go
on.
on.
Do you use new wire or do you add on the same wire?
Thank you so much for the question.
Thank you so much for the question. I think I didn't say it during the presentation, but I use the same wire if I think that I can move on the stiffness of the wire to do that bending, because I'm going to generate a lot of force, much force than I want. So I can use the same wire for that. And what I do in this situation is to grab in the same position that I did the first bend, and I'm going to enhance, to increase the angle of that band, and I'm going to increase the angle of the band, so I have a wider band now in the same arch wire or in the next arch wire. The most important thing here is: do you want to maintain? Do you want to keep that band that you did, or do you want to increase it? So you can do it either in the same arch wire, doing that, what I said, grabbing the same position and increasing the angle that you generated, or you can move to another arch wire, doing another bend. So another thing that is important and that I call the attention during the presentation is that you have to check what, before you do this, the insertion. You insert the arch wire inside the. This is what I do. I'm sorry, I don't have now the video, but I can do it.